So, the golden rule you have to burn into your brain right now: don't chase the diagnosis. Save the life first. Seriously, in a high-stakes emergency, trying to figure out the exact specific disease is just going to waste precious time you simply do not have. Your one and only job is to stabilize the human being right in front of you. Okay, let's hit step A, which stands for airway and cervical spine. You want to start with one incredibly simple question. Can the patient actually speak to you? If they can, great, their airway is likely patent. But if the answer is no, well, they are in immediate, grave danger, and you've got to act instantly. So you're looking for any physical obstruction. If you even suspect trauma, do a jaw thrust. Suction aggressively. Go ahead and insert an airway device, and if that still fails, you proceed straight to intubation. And you're doing all of this while strictly immobilizing that cervical spine. Keep in mind, an oxygen problem, that becomes a brain problem in just a matter of minutes. Moving right along, B is for breathing. Now, just because air is getting in doesn't actually mean the lungs can process it, right? So you need to crank up that high-flow oxygen and do a rapid sensory check. Look for chest rise, listen for bilateral air entry, feel for tracheal deviation. It is quite literally a full sensory assessment happening in mere seconds. And you are doing this to immediately rule out 4 absolute killers: tension pneumothorax, massive hemothorax, open pneumothorax, or flail chest. Actually, this is exactly where bedside ultrasound totally shines. It's like having a superpower, letting you peer right into the chest cavity in real time to see exactly what we're dealing with. Next up, C is for circulation. The big question here: is the patient perfusing? Look, you don't need to wait around for lab results to tell you this. Just rely on those immediate clinical markers. Check their pulse, their blood pressure, skin temp, capillary refill, and even their mental status. Your absolute first priority here: stop any catastrophic bleeding. Then, secure 2 large-bore IVs, send off your bloods, and start pushing fluids. And while you're treating them, you're going to use that ultrasound again as your 5th vital sign to hunt for the specific cause of shock, whether it's hypovolemic, cardiogenic, obstructive, or distributive. All right, bringing us to D and E, which actually require totally different approaches. Disability is this lightning-fast 10-second neurocheck just to find reversible causes, like, say, hypoglycemia. But exposure, that means completely stripping the patient. Why? Because you're only going to find what you expose. It's that simple. So you're looking for hidden bleeding, burns, or scars. But the second you've done that, you must immediately pivot to aggressively preventing hypothermia. Grab warm blankets, use fluid warmers. The absolute golden rule here: never, ever sacrifice core warmth just for your exam. Cold trauma patients die, and we want to prevent that for sure. Ultimately, the primary survey is a completely dynamic mindset. You assess, you intervene, and you reassess. You find it, you fix it, and you repeat the whole shebang. But look, knowing these steps is really only half the battle. When those alarms are blaring and the seconds are literally slipping away, how will you react when the ultimate pressure is on you?